PYQ फॉर साइकाइट्री, कैसा चल रहा है साइकाइट्री का हाल? तो लेट्स वेट. हेलो. हाय गाइस. नो साउंड, वी आर फिक्सिंग इट. 2 मिनट लगेंगे बस, फिर PYQ सॉल्व करते हैं. गिव मी अ थम्स अप अगर साउंड आ रही है सही से. जैसे ही साउंड आने लगेगी मुझे हाँ बोलना प्लीज. ऑडिबल नाउ. ऑसम. थैंक यू गाइस. तो कैसा चल रहा है साइकाइट्री का, क्या हाल चाल है, पहले ये बताओ. हाउ इज एवरीबॉडी डूइंग? साइकाइट्री पढ़ ली, खत्म हो गई, या सिर्फ PYQs करने आए हैं? हाय शरण, क्या हाल है? सन्यासी पंडित. सन्यासी पंडित, वेरी इंटरेस्टिंग नेम. सो साइकाइट्री करेंगे शॉर्ट शॉर्ट आज तो डेफिनेटली. हाउ इज एवरीबडी फीलिंग टुडे? अच्छा, मेरा ना फर्स्ट यूट्यूब लाइव है तो मेरे पे थोड़ा सा शांति बरतना, थोड़ा सा कम चिल्लाना अगर कोई टेक्निकल ग्लिच हो. एंड डेफिनेटली साइकाइट्री के बारे में कोई प्रॉब्लम नहीं आएगी, पर साउंड के बारे में और कुछ प्रॉब्लम आए तो प्लीज बता देना. स्टार्ट करें, हल्के हल्के से स्टार्ट करते हैं और लोग ज्वाइन करेंगे. ऑलराइट. तो मेरा ना एक बहुत फेवरेट तरीका है, मुझे कहानियां सुना के सिखाने का बहुत मजा आता है. सो लेट्स रीड द क्वेश्चन, फिर स्टोरी सुनाऊंगी. During psychotherapy, the therapist had mixed conscious and unconscious feelings towards his patients. This is known as. तो पहली बात तो थेरेपिस्ट AKA डॉक्टर इस केस में, ठीक है. और ऑप्शन है काउंटर ट्रांसफरेंस, डिसोसिएशन, ट्रांसफरेंस एंड प्रीऑक्यूपेशन. अच्छा, आंसर बता रहे हो बड़े सही से, वेरी नाइस. एंड आंसर भी सही बता रहे हो, बट पहले एक बारी कुछ समझाती हूँ. तो ना, एक बारी मेरे पास एक पेशेंट आई थी. शी वॉज इन हर 70 लेट 70s में थी. तो उनसे बात करते करते जब वो स्माइल करी ना, मुझको एकदम से मेरी दादी जी की याद आई. और जैसे ही मुझे मेरी दादी जी की याद आई ना, उसके बाद मैंने देखा कि मेरा एटीट्यूड शिफ्ट हो गया उनकी तरफ. मैं उनको जैसे ट्रीट कर रही थी उसके जगह में थोड़ा सा और ज्यादा सेंसिटिवली और थोड़ी सी एम्पैथी देके ट्रीट करने लगी. तो दिस इज समथिंग दैट रियली डज हैपन इन आवर फील्ड व्हेन यू आर सिटिंग अक्रॉस अ चेयर. आपको भी किसी भी फील्ड में हो सकता है, किसी भी डॉक्टर को हो सकता है. और करेक्ट आंसर इज काउंटर ट्रांसफरेंस, एब्सोल्युटली राइट. बट क्यों ये आंसर आया उसकी तरफ जाते हैं, क्योंकि हर टर्म भी समझ लेते हैं एक बार. ऑलराइट. तो आंसर है काउंटर ट्रांसफरेंस गाइस. डेफिनेटली दिस इज काउंटर ट्रांसफरेंस. मगर ट्रांसफरेंस क्या है, काउंटर ट्रांसफरेंस क्या है, ये कोर डिफरेंस समझते हैं. उससे पहले एलिमिनेट करते हैं डिसोसिएशन और प्रीऑक्यूपेशन को. देखो, प्रीऑक्यूपेशन तो इज जस्ट अनदर टर्म फॉर बीइंग वेरी प्रीऑक्यूपाइड विद समबडी. तो ये तो मैंने राइट ऑफ द बैट काट दिया, इसका कोई एक्चुअली कोई टेक्निकल क्लिनिकल मीनिंग नहीं है. डिसोसिएशन इज अ टाइप ऑफ डिफेंस मैकेनिज्म, राइट. तो ये एक टाइप का डिफेंस मैकेनिज्म है, तो ये यहाँ पे नहीं फिट होता है. मगर व्हाट इज ट्रांसफरेंस, व्हाट इज काउंटर ट्रांसफरेंस? लेट्स सी दिस पिक्चर. मी एंड थेरेपिस्ट. मी इस केस में पेशेंट है, ठीक है. और पेशेंट के पास्ट लोग और थेरेपिस्ट या डॉक्टर के पास्ट लोग. तो जैसे मैंने बताया, मेरे को मेरी दादी की याद आई उनसे बात करके, राइट. और उनको भी मुझसे बात करते करते बड़े सारे लोगों की याद आ सकती है. मे बी अगर कोई पेशेंट है, उनको मैं अपनी उनकी बहन जैसे दिख रही हूँ, या याद आ रही हूँ, या उनका पिछला डॉक्टर के साथ अच्छा ट्रीटमेंट नहीं हुआ, तो उनको एक बैगेज है डॉक्टर के अगेंस्ट. तो एज अ डॉक्टर मेरी तरफ व्हाट पेशेंट हैज टुवर्ड्स डॉक्टर और थेरेपिस्ट इज कॉल्ड ट्रांसफरेंस. तो मैंने अपनी एनर्जी ट्रांसफर कर दी, ओके, पेशेंट ने. एंड काउंटर इज व्हाट ऑपोजिट डॉक्टर हैज टुवर्ड्स द पेशेंट. गॉट इट? So you can see in this diagram very clearly, counter is from the therapist or the doctor towards the patient, me being the patient here, and the vice versa. But at the same time, I want to go back and read two more important words. There was a term called conscious and unconscious feeling here. So we also have to dig in. Remember, in PYQs, we don't only read the topic that is there, we also try to do any sister, brother, concern topic around the question that was framed. So I found two interesting words. One, I found the defense mechanism. So I said, yes, defense mechanism B, we should go back and quickly revise. So if I have to talk about defense mechanism, one thing that we must know is the matured defense mechanism. Okay. How to get the questions? You can take the screenshot of these questions. Definitely. That's how you can get the questions. But at the same time, I'm making up newer questions, and newer questions are something which is close to the current question. So, mature defense mechanism. Who will tell me the mature defense mechanism? I'll wait for the chat window. Should I write down or should I first wait for you all? And I'll have to move out of the way. So, who will tell me the mature defense mechanism? Because I already mentioned dissociation here, which is not a defense mechanism, mature defense mechanism, it's immature. So, can someone tell me the mature defense mechanism? Sublimation. Excellent. So, this is the mnemonic, guys. I'm going to move out of your way to show you the mnemonic. So, this mnemonic is SMASH. SMASH is a mature defense mechanism mnemonic, and it stands for the full term. Sorry guys, like I said, technical difficulties first है मेरा YouTube पे, तो इसलिए I don't know how to move out of the way, but मैं बताती हूँ आपको. S is for sublimation. SASH सही है, मैंने उसको SMASH बनाया because SMASH is easy to remember, you smash it. Sublimation stands when you take impulses which are not societally acceptable and convert them into something societally acceptable. For example, a person who becomes a surgeon may have impulses to cut people up, and then now they have turned into a surgeon. So that is sublimation. M is just for mature here. A is altruism. Altruism is when you do something for someone else. Suppression is when you suppress, you don't want to attend to this particular anxiety provoking feeling, so you defend yourself by suppressing it. It is the only conscious, suppression is the only conscious defense mechanism. All other defense mechanisms are unconscious. Okay. And H is for humor. Haha. Chandler Bing, right? From Friends. Now, coming back, we have understood what transference is from the patient towards the doctor or therapist. We've also covered what the doctor has towards the patient is counter transferent. Any doubts up till here? Feel free to ask definitely in the chat box. I'm here to answer any psychiatry queries for y'all. Now, having said that, because the term conscious and unconscious were formed in the MCQ, you can see these two terms were in it. I want to also highlight a little bit about these two terms. Now, remember, Freud gave us this theory, structural theory called the iceberg model, and he said that we can divide things into conscious mind, what we can actually see, the pre-conscious, which is between the conscious, and the unconscious, which is under the surface. So an example would be, consciously me teaching you is definitely a conscious part. Unconsciously, there are topics which are popping up while I'm teaching this also, and the pre-conscious is the filter which decides should it go towards the conscious or not. Okay, let's move on to the question number 2, guys, right? Questions, please drop them, and definitely let's try to solve this one. It's a very important topic when it comes to psychiatry. An alcoholic Quelling stopped alcohol consumption for 3 days and presented with irritability, okay, disorientation, paranoid delusions, agitation, visual hallucinations, and altered sensorium. What is the likely diagnosis in this case? Is it delirium tremens, Wernicke's encephalopathy, Korsakoff psychosis, or alcohol-induced psychosis? Okay, a lot of people are answering. I want to start from what, but most importantly, I want to also highlight how you should arrive upon this answer and how you should not get confused. Remember, alcohol is a super important topic, guys. Definitely give it your 100%. It's going to be worth it. Some questions will pop up from there, most likely. Now, Why is it not alcohol-induced psychosis? Let's start from the bottom to top. The answer is delirium tremens, as rightfully said by almost everybody in the chat box. Okay. Why is it not alcohol-induced psychosis? The alcohol-induced psychosis doesn't necessarily happen while actively consuming alcohol and persists even after alcohol consumption has been stopped. So we negate it. Korsakoff and Wernicke's encephalopathy are chronic. Both of these are chronic disorders and are not acute disorder. Whereas the presentation above is clearly acute. There is clearly altered sensorium. And if you can also think, altered sensorium is a hallmark for what? For delirium. Okay. So delirium is very categorically in alcohol called delirium tremens, and hence delirium tremens is the right answer. Now, what are the features of delirium tremens? As you can already see, there's visual hallucinations, there could be delusion supporting it, there is irritability, disorientation to time, place, and person, there's tremors, altered sensorium. I have a mnemonic for you. Who's a fan of mnemonic? Pehle batao. Who likes mnemonics here? I will give you a mnemonic if you like mnemonics. Otherwise, I'll skip it. Any mnemonic fans? Mnemonic fans, give me a cheer. Yes, no, maybe. Okay, a few. Everybody's a mnemonic fan. I agree. Me too. So here is a mnemonic for delirium tremens. Now, how I want you to remember this, again, story time. I think things are remembered better when we have a story around it. This happened to me. A patient in delirium tremens once tried to hit me. And that happens when patients are in delirium, they unfortunately become aggressive and they can hit you because they're not really oriented to time, place, and person. They don't know you are the doctor. They don't know who's who. So this is a mnemonic that I've created called HIT doctors. So the short form is HIT doctors. Delirium tremens patients hit doctors. Now HIT is square. H is for visual hallucination. Notice, where do we find visual hallucination? Often we find them in these conditions, which are organic conditions, which are substance-induced conditions, whereas auditory hallucination are the most common in schizophrenia. Second is hyperactivity, which is autonomic hyperactivity. Now, in autonomic hyperactivity, there is an elevation in heart rate, in your pulse rate, and your respiratory rate. Everything goes through the roof. Next is irritability. So that is the I. Insomnia. So these patients actually sleep wake cycle is disturbed. Okay. Tremors, coarse tremors, and there's tachycardia already mentioned above. Disorientation to time, place, and person. Diaphoresis, which means sweating. Delirium. This is again difficulty, altered consciousness. And the REM cycle is disturbed. They usually wake up multiple times in the night. Sweating, shaking, slow to fast. So again, features को मैंने subdivide करके I made them into smaller bits, but this is how you can remember delirium tremors. Here's another hack that you must try to remember. How to remember what happens when? Because another question could be framed in the above question. Imagine it was not at the 3-day mark. Imagine the sensorium was not altered. Imagine the question only had, what if the patient presented with tremulousness? Tremulousness means shaking of the entire body, GI symptoms, which is gastrointestinal symptoms, and autonomic system is stimulated. It's very high, activity is very high. And the patient has stopped drinking only for 6 to 8 hours. Maybe they just finished drinking, they've been chronic alcohol use, and now they have stopped drinking. Now, if the time frame is 6 to 8 hours, your answer will be mild amount of withdrawal. So this is alcohol withdrawal. And you will categorically say that it's the stage of tremors. Next is obviously the hallucinosis. What is hallucinosis? That the conscious is preserved. The person is not confused here. Okay, they're very conscious. In this, hallucinations are visual or auditory. In alcoholic hallucinations, again, first of all, the conscious is preserved, meaning the person is oriented to where they are. And yes, it is mostly visual along with auditory as well. Whereas purely auditory are usually seen in schizophrenia. So organic conditions, we find more visual hallucinations. Good question. Now, in alcoholic hallucinosis, you'll find it around 12 to 24 hours. So roughly 1 day, half a day to 1 day. Severe is something called seizures, which is cluster seizures. Why are they called cluster seizures? Because in a short span, like 3 to 6 hours, you may have multiple seizures. And they're also called rum fits. What kind of seizures are they? What is GTCS? Who will give me the full form of GTCS? And they happen typically at the 1 to 2 day mark, half to 1 day. Who will tell me what is GTCS? Come on, GTCS, guys. Full form of GTCS. And finally, the most life-threatening, because there is a high mortality rate, is tonic-clonic. Yes, generalized tonic-clonic seizures. Yes. And in high mortality rate, we have delirium tremens, that is day 3, which is 48 to 72 hours. Now, here's my hack. You can steal my hack. What is my hack? 8, may T is the ending. The last word in 8 is T, right? T for tremors. 8 tremors. So around 8 hours, tremors. 11, and I stole this from somewhere. I don't create all my mnemonics. I'm not going to make tall claims, okay? But I like borrowing what works for everybody and then giving to other people because baantne se badhta hai, right? And 11, in hallucinations, you can see the two parallel L's, which stands like 11, and that is hallucinations. In 22, seizures, if you think like 22, and if you think the word seizures, they look like 22. So that is around 22 hours. That is around 1 day roughly. And finally, we have tremens. Tremens sounds like tres, like 3. In the certain languages, tres means 3. Okay, un, dos, tres. So tres is 3. So this is at the 3-day mark. So this is how you remember alcohol withdrawal. We've covered practically everything around alcohol withdrawal. All right, except for the question also formed for 2 chronic conditions related to alcohol. So somebody wrote a nice answer. Somebody already mentioned Goa features. Good. Now we're going to look at Wernicke's versus Korsakoff. Who can tell me the difference between Wernicke's versus Korsakoff? This question actually, interestingly, is one of the questions asked in the PYQs only. I will cover it again in the end. But I want to know from you all who has already studied difference between Wernicke's and Korsakoff. Both are chronic conditions, for sure. Come on. Severe form is Korsakoff. Okay. Of what? What is the main deficiency? Deficiency of what? My biggest question to you is which deficiency? Thiamine. Excellent. Which vitamin is thiamine? B1. Excellent. So let's look at Wernicke's versus Korsakoff. Right. What do you see in this picture? Chalo. Tell me what you see in this picture. You'll never forget Wernicke's versus Korsakoff after this. What do you see in this picture at the moment? What is visible in this picture? Do you see a coat and do you see a rack, a coat rack? This is my mnemonic for Wernicke's versus Korsakoff. Goa is a very common mnemonic. I like it. I really like it. Goa is also a very good way of remembering Wernicke's. But what is coat rack? Okay. So, गोवा बताओ क्या होता है? हम तो कुछ और बोल देते. Okay. अच्छा कि आपने नहीं बोला because this is a coat and a rack and that is pretty visible. Ophthalmoplegia, ataxia, and thiamine is the issue, right? All right. So this is Wernicke's. Now in Wernicke's, if you already know the Goa, you know it is global confusion, ophthalmoplegia, and ataxia. Any idea which cranial nerve is involved? Which cranial nerve is involved in ophthalmoplegia? Come on, guys. Cranial nerve involved in sixth. Excellent. So it is the sixth cranial nerve, lateral rectus palsy, right? So you can see one way of remembering is GOA, of course, global confusion, ophthalmoplegia, sixth nerve, ataxia. The other way that I did tell you is C for confusion, O for ophthalmoplegia, A for ataxia, and the thymine is the one that you need to fix. It is a thymine issue. What kind of memory is affected in Korsakoff? Anybody? Which kind of memory, which kind of amnesia happens in Korsakoff? Anterograde, retrograde. Great, both, right? So both kind of amnesias happen in Korsakoff. Korsakoff is a more serious form. Yes, if you would like to see this table, clearly we can see the differences that Wernicke is slightly more acute than Korsakoff, and it is reversible. However, it can progress into Korsakoff. Korsakoff is purely more chronic. Now, Wernicke is acute compared to Korsakoff. It's over prolonged use of alcohol. Both are because of prolonged alcohol use plus nutritional issues. Anterograde is more common than retrograde, right? And confusion is definitely there in Korsakoff, ophthalmoplegia, rectus palsy, and thymine is the one that you give immediately. Which part of the brain is involved? Mammillary body in Wernicke's, and you give thymine for 3 months, most likely reversible. Whereas in Korsakoff, if you see, yes, retrograde, anterograde, and confabulation, which means they make up stories. You know, when you ask them, okay, how did you come to the OPD today? So they'll say, oh, I actually, they won't remember how they came. So they'll say, oh, I actually went to the market and I got onto a bus and then I went to Pune, and then from there I was able to get onto another plane, and then from there I went to another place, and then I came here. So they will have made up stories, okay, which is not true. Honest life, yes. And in Korsakoff, it is mammillary body plus other parts are also there, and thymine has to be continued for a long period of time. May not reverse. There's not a rule of thumb that it will reverse. Okay, next, let's move on to the next one. A teacher demonstrated the steps of hand washing to her students. Students performed the same activity later at school and at home. What is this type of learning known as? Is it affective, psychomotor, cognitive, affective, and cognitive? Okay, so what is affective learning? It is where there is emotions involved. Okay, psychomotor is basically more show and do, and show and do, like basically you are doing surgery is psychomotor. Okay, and cognitive is more learning and information based. Dextrose भी देते हैं with thymine. What to give first? Always thymine, please. Never give dextrose, definitely, because it will cause worsening, and the patient can actually, you must always load first with thymine and then give dextrose. Rule of thumb. Okay. Previous question के लिए पूछ रहे थे ये, and that's a good question. Now, affective learning is through emotions. Psychomotor is through showing and doing. Cognitive is by giving information. Now, what kind of learning are we doing right now? We're obviously doing a lot of cognitive learning, right? Psychomotor, I am showing you certain things, how to break them down. Part of it can also be considered that. So by teaching someone steps and asking them to repeat it by learning, show and do is basically psychomotor. All right. Surgery, for example, you know, you'd be seeing and doing. So that is psychomotor. Cognitive is more funds of information, and affective and cognitive, of course, नहीं है. तो ये काफी straightforward था. Okay. Can we move on to the next one, guys? Next question. B, C. कौन से का आंसर बता रहे हैं? All right. Which of the following is a formal thought disorder? Obsession, derailment, delusion, thought insertion. Okay. So let's see. Let's start with first. What is the thought disorders in the stream? Anybody? Anybody who can tell me? Form का करेंगे, of course. We're going to talk about the formal thought disorder, but stream में कौन कौन बताएगा? Stream. Can somebody fill up stream for me, please? Flight of idea. Great, great. Okay. और फ्लाइट ऑफ आइडिया क्या होता है? Schizophrenia. Flight of India. Mania. Okay. So we'll focus a little bit on all. Flight of ideas is like taking off and going from one place to another and not landing, right? So essentially, flight of ideas would be me starting a chain of thought, but jumping from one thought to another. That is the stream issue. All right. Form means form. It means the akar, the shape, right? That is the form. Now, what is derail? What is derail? Hello. Yeah, what is derailment and what is circumstantiality, what is tangentiality, and loosening of association. So let me give you a visual understanding. Can you see me? I actually lost my internet for a second because of a call. If you can see me, please give me a thumbs up. If you can hear me, please give me a thumbs up. I did lose some connection here. Hello. Hi guys, can you? Okay, thanks. Thank you, Sanasi Pandit. Yeah, you can hear me. Thanks. Right. So, coming back, I want to focus on the form of thought now. Derailment, circumstantiality, tangentiality, and loosening of association. ये चार करते हैं, ठीक है? So, this is my train की पटरी. This is my train track. I am telling you a story, but I suddenly go off track. That is derailment. Now, for example, you ask me, so doctor, how's your day today? And I'm like, oh, you know what? I was going to eat some food and there I saw the dog and I became completely obsessed with what is that movie's name? Now, you see, there is no association between the points. So I've gone off trail, off topic. All right. Next is circumstantial and tangential. Now, let's say I start from point A, but I never reach point B. That is tangential. But if I do reach point B, then it is circumstantial. So I'll tell you the difference. Meaning, let's say you ask me, so how's your day today? Now I start saying that, you know what? I woke up in the morning, I brushed my teeth, I went outside to go get some milk. And after that, I decided that, it's time to shower. I took my dog for a walk. And then I found myself lost in the market. Then I bought some vegetables. So you're like, okay, but I asked you, like, how was your day? How is this like answering the question? And then you eventually come, oh, by the way, my day was nice. Now, if you reach the point, गोल गोल घुमा के you have reached the point. That is circumstantial. Tangential is like a tangent. You just missed the point. That is tangential. So missing the point is tangential. Staying on track is coming back eventually on the goal directed question is circumstantial. Okay. So that is the different kind of, and loosening of association is when two forms, the two sentences have no relation to each other. For example, hi, how are you? What's your name? Now, these are two questions with two separate parts. These are two separate entities. But if I say, okay, tell me more about yourself, and I say I am a doctor. Yesterday, Elon Musk sent a satellite in the International Space Center. Now, these are two unrelated sentences. So the association is lost, is called loosening of association. All right. Now, we're going to see which of these is a formal thought disorder. So as you can see, out of these, derailment is a formal thought disorder. What is obsession? Who will tell me? Delusion, I have already told you, is definitely of content. What is obsession? It is a disorder of, come on, ये tricky question है. Obsession is a disorder of, I'm very unsure at this point whether my questions are reaching you all, so I'm leaving it in the text box. What is obsession? Obsession is a disorder of, who can answer what is obsession a disorder of? Which kind of thought disorder is obsession? Obsession is a disorder of, I'm waiting, somebody, possession. Okay, correct. Absolutely. This is a tricky one. According to the last few PYQs, obsession is a disorder of possession. Actually, there's a debate between what Fish says and what our CTP says. But yes, possession agar aaya, then obsession is under possession. Remember that. Okay. Followed by content. Good. Very good. That's why I didn't write it here. But please stick to possession as the answer for obsession. Thank you. Should we move on to the next question? 20-year-old girl presented with overfamiliarity, flight of ideas, we just talked about it, mood is elevated, increased sexual desire, and pseudo hallucination. What is the most probable diagnosis? Is it mania, hypomania, cyclothymia, or schizophrenia? Answer, please. What is the answer according to you all? What is it? Is it mania, hypomania, cyclothymia, schizophrenia? Then I'll tell you why is it not what we cancelled. All right. How do we get to the answer? A, mania. C, cyclothymia. D, schizophrenia. A, okay. All right. 2 votes for A. 2 votes for C. एक और vote for D. Then we'll have a joint tie-up. History of days. Excellent question, by the way, Surya. Very good question. Okay. Now, let's say that I will give you the days as 7 days. Now, what is your answer? D, schizophrenia. A, B. All right. So let's see what it is not to what it is. All right. It is not schizophrenia simply because for schizoaffective disorder, you need to have both the features of schizophrenia plus mood disorder, and you need to have some psychotic symptoms in the absence of the mood disorder. No such history is given here. So there you go. I cancel D out. It is not cyclothymia. Simply put, why? Because for cyclothymia, you need 2 years or more of symptoms that do not fully meet, not fully meet bipolar, that is manic or hypomanic symptoms. Okay, so do not fully meet manic symptoms, right? So remember, it is not cyclothymia. Between mania and hypomania, one, clearly there is overfamiliarity, flight of ideas, elevated mood, increased sexual desire, and pseudo hallucination. Now, pseudo hallucination is the word which confuses all of us, right? That's why a lot of you said schizophrenia. What is pseudo hallucination? What is hallucination? Tell me. What is pseudo hallucination? What is hallucination? Come on, Dr. Mishra, Sannyasi Pandit, what is pseudo hallucination and what is hallucination? Inner subjective space is pseudo hallucination. And one more major difference. It does not meet the full properties for hallucinations, right? So hallucination has certain properties. And inside, okay, inner subjective space, pseudo inner hallucinations, okay. And Atma ki savaj, okay. Insight, good. Insight is there, definitely. And one more thing, in hallucination, typically not under our control. Pseudo hallucination may be under your volition, maybe under your control also. So don't get confused by pseudo hallucination. All right. But because of the degree of the problem in this context, increased sexual desire, elevated mood, flight of ideas, overfamiliarity, pseudo hallucination, the most probable diagnosis will be mania. Let's see what is bipolar affective disorder in that context. Independent of will. Yes, that was the right word. Independent of will, right? In bipolar affective disorder, this is a typical, we're just understanding bipolar from a stance of almost everything related to symptoms of bipolar now, getting into the depth of it. So there is high mood, which is the top pole. There is low mood, which is the low pole, north pole, south pole, right? And in between is the normal pole, which is the normal mood. Now, the highs are called mania. The micro highs are called hypomania. And of course, it has to be less than 7 days, right? 4 days typically. And lows are called depressive episode. Now, in bipolar affective disorder, what is bipolar affective disorder 1? What is bipolar affective disorder 2? Who will tell me? What is bipolar 1? What is bipolar 2? Mania 1, hypo 2. Good. So, mania plus major depressive disorder or only mania, hypomania plus major, MDD is major depressive disorder. Okay, guys? Major depressive disorder. Remember bipolar 1 and bipolar 2. These are also relevant subtopics. Symptoms of mania is always 1. Yes, absolutely right. Mania is always 1 and hypomania is 2. Okay. This girl presented with more manic features. Why? Now I'll show you the features of mania. Now think of a dog who's in a complete manic phase. He will be digging fast. He'll be digging very, very fast, right? So in dig fast, we have the mnemonic, which is the person is very disturbed. He's very impulsive, very grandiose. Flight of ideas is there. Activity is increased. Sleep is not needed. I don't need to sleep. And there is pressure of talking. That is pressure of speech, right? So this is the ICD diagnosis of mania is that for a duration of 7 days or more, or if the patient gets hospitalized before 7 days, of course, the hypomania symptoms will be less, of course. The mood is either excited, expansive, elated, dysphoric, or irritable. Now, you need 3 or more symptoms from these if the mood is high but you need 4 or more if the mood is irritable. So if the mood is irritable, you actually need more symptoms. And what are the symptoms? One is reckless behavior. We found that in the previous one. Over sexual, yes. Grandiose, I am the king of the world. I am an actress without actually being in that profession. I am God. I can make it rain. You don't know who I am. I know prime minister. I know chief minister without really actually in reality knowing. And the sleep need is reduced or needed. Psychomotor agitation is there. The person's constantly pacing up and down. These patients will not sit in your OPD. They will keep pacing. Flight of ideas, talking about many things. I can do this and that and that and that and that. Increase energy and racing of thoughts are there. Okay. So any doubts in mood disorder before we move on to the next one? I'll wait for everybody to tell me whether there is any doubts in this. Any doubt in mood disorder, please? In bipolar disorder, particularly? In hypomania, you will not have all the things to that much gravity. There will never be grandiose delusions. There are never delusions in hypomania, and the distress is not as much as mania. And the duration difference is there that you've already mentioned. Any questions? Please ask. Feel free. Let's move on to the next one, right? We have a few more. Okay, so 18-year-old girl, intense craving for food, eats large amounts of food, which is followed by self-induced vomiting. What is the probable diagnosis? Is it atypical depression, bulimia nervosa, anorexia nervosa, or binge eating disorder? Let's see. B. Drug of choice for mania. Okay, mood stabilizer would be the most recommended. However, mood stabilizers take time for acting in, except for antipsychotics, which does work faster. So you have mood stabilizers, antipsychotics, and you also can use benzodiazepines to calm the patient at that time. This is the treatment of flow, and ECT can also be given. Okay, treatment for bipolar. Right? Okay. Now, large amounts of food, self-induced vomiting. Ate too much, feel very disgusted with myself. I hate that I will put on weight. Let me throw up. Now that you have to tell me the answer B. Bahut badhiya. Everybody has got bulimia right. Why is it not atypical depression? Who will tell me what is atypical depression? Remember, the PYQs are an insight to what can be asked from atypical depression can also be asked. Binge eating disorder can also be asked. So the subtopics are also that, the choices are also that important. What is atypical depression, guys? Mood is reactive. Interpersonal rejection, sensitivity. Old people, mercenary, I don't know. Sensitivity and eating increases. Sleep increases. Glucose cravings, good. Eating carbohydrates, sleeping more. Interpersonal rejection sensitivity, mood is reactive. And what happens to the leg? Who will tell me this word? No, what is leaden? Your legs feel really heavy while walking. That is called leaden paralysis. You feel like your legs are made up of lead pipes. Okay, leaden paralysis. So that is, yes. Leaden. Yes, leaden paralysis, which means like your legs feel like it's made up of lead. So that is atypical depression. Now, clearly in this situation, we did not find it. Between anorexia and binge eating disorder, in anorexia, there is not eating of large copious amount of food, but there can be behavior which is like self-induced vomiting. Okay, so compensatory behavior can be there. In binge eating disorder, there is not any purging or laxative. Vomiting is also called purging. Remember, it can also be called purging. Okay, that's purging. But in binge eating disorder, there is no purging, and in anorexia, there is just fear of eating. So they will not even eat large amounts of food. Okay, here is how I'd like you to remember the differences, please. Here are the differences between anorexia, bulimia, and binge eating disorder. Okay. Now, actually, bulimia is the most common, far more common than you'd imagine. Anorexia, there is an emphasis on the caloric restriction. I don't want to eat through intake of only voluminous food. So, eating very, very less amount of food, right? Panipilia. Now, binge eating, there's episode of binge eating followed by typically, binge eating, there is no purging. Whereas in bulimia, there is binge eating followed by, yes, they will always purge. When it comes to anorexia, they're very concerned about nutritional facts. Like, they will be constantly thinking, reading how much calories is there in this, what will happen, what will happen, what will happen. And in binge eating, there's just a lot of shame and disgust for self. How did I eat so much? Why did I eat so much? Whereas in bulimia, there is purging behavior like vomiting, laxative, diuretics, and you may also go into fasting cycles. Remember, in anorexia also, there can be compensatory behavior. Okay. Their anorexia, there's debilitating fear of weight gain. They're very thin. So I like to draw this picture. Okay. This is anorexia. This is bulimia. And this is essentially binge eating, right? Now, this person is in anorexia, you're very, very skinny. And you can even have amenorrhea. One of the MCQs from one of the previous years was what happens in anorexia, and one of the options was dysmenorrhea, and one was amenorrhea. So amenorrhea is the right answer, not dysmenorrhea. And in binge eating, you keep eating. हम सब भी binge eating करते हैं. One of us has definitely binge eaten once or twice in our life. And there's also frequently eating along in secret, whereas in bulimia, there are callus, there's dental caries, there is also drinking excessive amount of water and fluids to fill your tummy up. So purging to ma'am anorexia hota hai. Yes, I said compensatory behavior can happen in anorexia also, but the amount they will eat will be very less. In bulimia, the amount will be big. Okay, and in anorexia, hallmark, they're extremely fear of gaining weight. While bulimic people also don't want to gain weight, bulimic people can actually be on the more obese side or on the more normal weight size. Anorexia people are extremely low weight. Okay, good question. So let's look at the next question. A woman who is 4 days postpartum, how many days? 4 days, presented with tearfulness, mood swings, and sometimes not sleeping very well at night. Okay, what is the likely diagnosis? Postpartum psychosis, postpartum anxiety, postpartum depression, or postpartum blues. Why is it not postpartum depression? Tell me. I want you to explain it to me. Everybody's saying D, good. Postpartum blues. Why is it not postpartum depression? Okay, I get it. It's not postpartum psychosis because there is no feature mentioned that, there is any loss of touch of reality. There's no delusion. There's no hallucination. Okay, I get it. It's not anxiety. There are no anxiety features mentioned. Longer symptoms. 4 days is longer. Oh, for postpartum depression, you need longer symptoms. Excellent. You also need more severe symptoms. Duration less than a week. Excellent. Wow. I think it's a topic everybody already knows. More than 2 weeks? Okay. Great. Very good answer, guys. Now, what you need to know is that you are absolutely right, everybody. Postpartum blues happen in the first 3 to 5 days. Actually, around 85% women can have it. It's that common. Okay. Whereas around only 50%, 15% women have like about postpartum depression. Okay. Having said that, in postpartum depression, it is usually in the first few weeks to months after childbirth, right? First 3 months, it can happen at any time. And you're right, depression requires a diagnosis for more than 2 weeks to last, longer than 2 weeks. Severity of symptoms when it comes to postpartum blues, it's quite mild and transient, whereas in postpartum depression, it is severe, impacts day-to-day functioning. This person had occasional insomnia. This person was tearful sometimes, not all the time. Mood swings are there, tearfulness is there, anxiety is there, irritability is there, fatigue and difficulty sleeping, but not always. There could be difficulties. However, in postpartum depression, there's persistent sadness or emptiness. And there's a significant change in appetite or weight. So classical depression symptoms are there. When it comes to treatment, one of the questions can also be around treatment. What do you do for postpartum blues? You support and educate. You educate and support. Whereas for postpartum depression, you give CBT medications and support. Okay? So there is a difference there, right? Okay. Shall we move on to the next question now? Okay, so postpartum depression भी समझ लिया, blues भी समझ लिया. Now, okay, you're running fast. A patient with schizophrenia who didn't respond to risperidone and thyroidazine was started on a drug named A. So this is a hypothetical drug, okay? The drug's name is not A. And after starting drug A, the patient's psychotic symptoms have improved. Great. However, he developed excessive salivation, that is siluria. He's also had dyslipidemia and weight gain. What could likely be the drug A? Is it ziprasidone, clozapine, risperidone, or haloperidone? So, psych drugs are hard. Psych drugs are hard, yeah, but they're not impossible. That's what I want you to know. They are essentially, as you get, there are few that we have, but we use them robustly and over and over. So coming back, ziprasidone, clozapine, risperidone, haloperidol. Now, first and foremost, haloperidol is a first generation antipsychotic, second generation. Right. Now, clozapine is the correct answer, but here is the important thing. Clozapine is a very important drug. We need to remember it through a certain way. And how will we do that? Right? So, you need to first of all know how does clozapine work. Which receptor does clozapine work on? Chalo, batao. Which receptor does clozapine work on? Which receptor does clozapine work on? D2, D, 5-HT3, 5-HT2, D2. KK, you are absolutely right. D4 more than D2. And while obviously you have understood 5-HT पे भी act करता है, but D4 more than D2 is the correct answer, right? Where is clozapine used? Now, clozapine is used in treatment-resistant schizophrenia. And what is treatment-resistant schizophrenia? Treatment-resistant schizophrenia. What is treatment-resistant schizophrenia? There is not a standard definition of treatment-resistant schizophrenia, but what we like to believe treatment-resistant schizophrenia is when 2 or more drugs have been used and one of which is atypical or second generation antipsychotic. Okay, for optimum time duration and dosage. Dosage भी correct होनी चाहिए, and even though this thing has to be right. Correct, absolutely. You're right, Black Cam. I am so happy you mentioned. Clozapine also has anti-suicidal effect. But with all good things come not so good things. What are the side effects of clozapine? Who will tell me? You guys are doing a great job. Hello, Bharat, join us. What is the side effect of clozapine? Any idea? What are the side effects of clozapine? Anybody? So one side effect three side effects to mention here itself. One is that the person has excessive salivation. Another is dyslipidemia. Another is weight gain. But what are the side effects of clozapine is one part of the question. What are the life-threatening side effects of clozapine? So which one do you want to tell me first? Okay, life-threatening, pehle batao. What are the life-threatening side effects of clozapine? Guys, life-threatening side effect of clozapine. Who will tell me? Myocarditis. Excellent. One more. Agranulocytosis. Excellent. Two. Anything? Lipodystrophy. Okay, good. Wow. Myocarditis, agranulocytosis. One more. Seizure. Excellent. Great. So, the side effect of clozapine, myocarditis, absolutely right. Agranulocytosis, yes. Orthostatic hypotension, obviously not, it's not a life-threatening one. Seizures, yes. Metabolic side effects, it is the most weight-gaining antipsychotic, right? Most weight gain is there. Pneumonia, there could be impaired gag reflex, patient keeps on lying down, and there's so much of salivation, right? Increased risk of infection, again, because of the neutrophil count. NMS, it is used there, okay? And excessive salivation and drooling. In fact, it is used here also as a switch. Now, there is something called the wet pillow syndrome. What is it called? Wet pillow syndrome. What is wet pillow syndrome? Siluria. It is essentially when the patient, yes, absolutely, Ayush, you're right. When the patient sleeps at night, there's so much of salivation that the pillow becomes wet. Okay, so that is clozapine side effect for you. Next question. E, drug of choice. E, what is E? E to option nahi tha. A middle-aged female presented with complaints of repeated episodes for around 30 minutes, characterized by breathlessness, palpitations, sweating, hyperventilation, fear of impending heart attack. The patient has been having these similar types of episodes at least 4 to 5 times per month in the last 6 months, and the investigation did not reveal anything obvious. What could be the diagnosis? Panic disorder, generalized anxiety disorder, depression, or social phobia? A. E from clozapine. अच्छा, E from clozapine. Sorry, so sorry. नहीं था इसलिए नहीं बनाया. That's a good one. I was wondering why you're giving E. Now, what's the use for treatment for siluria? So first of all, you give patient anticholinergics to dry up the secretion because there's so much of excessive salivation. At the same time, one hack we learned on the wards for siluria is we tell patient to keep a chewing gum or a clove in their mouth. What happens when that is put in the mouth? You keep on swallowing it down, and there is lesser salivation, but anticholinergics obviously have to be given as well. Now, what could be the possible diagnosis is panic disorder. Absolutely right. Why is it not GAD? Why is it not depression? Why is it not social phobia? Now, clearly, social phobia it is not, because of the simple fact that it is not a situation where the person is put under a scanner and put on the pedestal and is supposed to perform. So we have cut out social phobia. It is not depression. We did not find any depressive feature like low mood, feeling out of sorts, losing weight, loss of appetite, loss of sleep. None of those. Why is it not GAD and why is it panic disorder? Okay, onset and impending heart attack. Excellent. Feeling of impending doom. Excellent. Now, one hallmark thing is, first of all, in panic attacks, acute onset is there. It goes up and it comes down. Okay, what goes up must come down. And typically 5 to 30 minutes it lasts. Okay, P for palpitation, T for tension, tightness, tremors, S for sweating, T for dizziness, discomfort, difficulty breathing, and impending doom. What does that mean? Oh my God, I'm going to die. Or feeling like I am losing control or going crazy. Some patients also say, I felt like I was going crazy. Okay, and it comes down on its own mostly, but with intervention comes down faster. Treatment will be SSRI, benzodiazepine for acute onset, and definitely you can even give a beta blocker. But actually, you need to do psychotherapy, and you need to guide and assure the patient that they are not dying. Okay, these patients typically run to the cardiology unit, and the cardiologist calls and says, there's this patient, it appears that CBT, absolutely, that there's this patient that is saying that they're having a they thought they're having a heart attack, young person, but they're actually not having a heart attack. We've done all the lab tests, this patient is having a panic attack. So this is typically panic attacks. Okay, what is the most common comorbid thing you find when patient starts having panic disorder? MCQ. What is the common comorbid with panic? I'll give you a hint. It starts with A, and it's not anxiety, but it starts with A. What is the most common? Phobia. What kind of phobia? Agoraphobia. Agoraphobia is quite common with panic. Okay, agoraphobia. Excellent. Agoraphobia is the fear of traveling away from home without assistance, or fear of moving out of the house, and these people become housebound. There's a MCQ sometimes called housebound housewife. Okay, so they become housebound. So that is another part of panic. There's also a lot of anticipatory anxiety. This is also a big thing we find. Matlab, even thinking about having a panic attack is very panicky for them. All right, a husband and wife presented to OPD with complaints of premature ejaculation. Of course, the husband is having premature ejaculation, which leads to frequent conflicts between them. Which of the following non-pharmacological treatments would be appropriate? Squeeze technique, sensate focus technique, exposure and response prevention, or cognitive behavioral therapy? Okay, so squeeze technique is the right answer. In squeeze technique, the penis is basically pressed on top the moment the gentleman feels that he's about to ejaculate. So it is a disorder of the orgasmic phase, right? There's an early ejaculation. According to DSM-5, premature ejaculation is when a person does not last 1 minute on vaginal insertion. So penetrative sex hone pe, if there is no not lasting for 1 minute, that is essentially called squeeze technique. Johnson technique, yes. Can you tell me what is sensate focus technique and where is it used? Can you tell me what is sensate focus technique? So I want to know what is sensate focus technique, and then I also want to know what is the erection problem. Yes, absolutely. Sensate focus technique can be used for erectile dysfunction. Essentially, patients who are having erection issues or even libido issues, you ask them to undo sex. You restart having sex from the basics. So you focus on one part at one time, and then the heightened arousal leads to better sexual chemistry. And yes, it is used in this thing. OCD for C, excellent. I was going to ask that ERP is the treatment of choice for OCD. But there is one kind of OCD for which it cannot be used. Any idea? One kind of obsessive compulsive disorder spectrum. Not, ये भी एक MCQ है guys. I'm just mentioning another PYQ. I think this was from INICET. I can't remember exactly. Not useful for hoarding. Okay. This was in INICET if I remember correctly, or FMGE. I can't remember, but है कहीं ना कहीं है. Okay. So definitely we've covered 2-3 more subtopics. So this is a sexual response cycle. As you can see, this is the excitement phase, plateau phase, followed by orgasmic phase. Erectile dysfunction is in the excitement phase. Premature ejaculation is in the distinct phase. Can somebody tell me the treatment pharmacological? for premature ejaculation? Who will tell me premature ejaculation's pharmacological technique? Which are the drugs that are used? Any idea? Premature ejaculation, pharmacological technique. SSRI. Good. Any particular SSRI you want to name? Doxepin. Less likely. Which SSRI? Oh, good. SSRI is right. Okay. Paroxetine. Any other? Paroxetine, fluoxetine, duloxetine, sertraline. Can someone tell me another group of antidepressant which can be used? Not venlafaxine. Not typically used for premature ejaculation. You can use venlafaxine, but again, trazodone. No. Trazodone has no sexual side effects. Secondary use of SSRI. Absolutely. So actually, SSRI cause delayed ejaculation. We use that for premature ejaculation. SSRIs cause delayed. Another group of antidepressant, guys, also used for premature ejaculation. No, bupropion also does not cause sexual issues at all. No. Okay, I've given you a hint. Which one? Which TCA will you use? Which TCA is used for premature ejaculation? Come on, hint de diya. No, not imipramine. Imipramine is a drug of choice. Desimipramine is a drug of choice for something else. Which TCA? Clomipramine. Okay, that is the other drug that we use for typically premature ejaculation. Okay, all right. A 40-year-old patient with a history of chronic alcoholism presented with complaints of confusion, ataxia, and ophthalmoplegia. The most probable diagnosis would be... What would be the most probable diagnosis? Wernicke, Korsakoff, delirium tremens, declarum bowel syndrome. Wernicke. We already did so much depth of co-track. Come on, co-track, remember? So, confusion, ophthalmoplegia, ataxia, give thymine. More reversible. And Korsakoff is retrograde, anterograde, confabulation, Korsakoff, right? Goa. Okay, you want to do Goa? I'm also happy with Goa as a mnemonic. Yes, global confusion, ophthalmoplegia, ataxia, right? Now, who will tell me vitamin B1 deficiency? Excellent, Ayush. We actually covered it in detail starting mein. You can go back. Who will tell me what is the last option? Declarum bowel syndrome. Come on, last question. What is declarum bowel syndrome? Last question. Declarum bowel syndrome. Anybody? No idea. Okay. Excellent, Ayush. तुम्हारा psychiatry पूरा हो गया लग रहा है. It is also called delusion of love or erotomania. Typically happens, it's a type of delusion, absolutely. Typically happens in females where they feel a male of higher status is, sorry, I'll just write it better, my hand is, where they typically feel that females have it more, where a male of higher status believed to be in love with them is called declarum bowel syndrome, erotomania. Absolutely. And with that, we are done with the PYQs. कोई doubt है? जल्दी से पूछ लो guys. Come on, I'm here to solve any queries if you have any. Otherwise, we're gonna log off and we're gonna study some more on our own after this. Any doubts, any questions? कैसा लगा? Feedback? Pace correct थी? Did you all enjoy the way of teaching? I like to use a lot of pictures. I like to engage a lot rather than just one-way teaching. It's very boring. Any questions, guys, to round up? Loving of high socioeconomic men, yes. Positive skills. Okay, बढ़िया था. Thank you. Positive symptoms of schizophrenia. Okay. So, पहली बात. Positive in this context doesn't really mean positive. Okay. I'll just tell you here only. I have some space here. Okay. Positive symptoms of schizophrenia are things which should not be there. But the good positive thing about that is that it has positive prognosis, better prognosis. And the positive symptoms of schizophrenia are delusions, hallucinations, and disorganized behavior or formal thought disorder. Okay, so things that should not be there but are there. Very bizarre, right? To have delusions, very bizarre to have hallucination, very bizarre to have disorganized behavior and formal thought disorder. These are the positive symptoms of schizophrenia. Can somebody round up and tell me the last question? What are the negative symptoms of schizophrenia? Or finish karenge? What are the negative symptoms of schizophrenia, guys? Negative symptoms, negative prognosis. Yeah, positive symptoms, good prognosis. Negative symptoms, bad prognosis. Catatonia, great prognosis. Anybody who can tell me the negative symptoms of schizophrenia? Anhedonia. Excellent, Ayush. Avolition. Good. Apathy. Good. Or. Evolution. Affect flattening. Good. And all A. बहुत बढ़िया. All A features. Asociality. Good. Great, guys. Solid. Everybody knows everything. All right. With that, I'm going to round up and I'm going to get done for the day. And please jao, khana khao and start studying some more. Have a great day. Thank you.